Just a courtesy announcement that we are live on the internet.
Hi, Gabby. I see you just joined us. Would you like to do a quick mic test? Hi, Gabby. I see you've joined us. Would you like to do a quick mic test?
Hi, good afternoon.
I can hear you. Thank you very much.
Thank you.
It looks like we have two Gabbies in the room. Is that a phone and computer, or is a shared link, or?
It's a shared link. We have a colleague that will be driving our PowerPoint today.
Should I rename one of the two?
Sure, that would be great. Could you rename it to Rebecca? And the last name is Lemus, Lemus?
Sure.
Thank you so much.
And Rebecca, would you like to do a quick mic test? And Javier, I see you've joined us. Would you like to do a quick mic test?
Good afternoon, Curtis.
I can hear you.
Thank you.
Thank you. And Chairperson Chavez, I see you've joined us. Would you like to do a quick mic test?
Thank you very much, Colin.
I can hear you and I can see you. And Moretta, I see you've joined us as well. Would you like to do a quick mic test?
Good afternoon. Thank you.
Thank you. Thank you very much.
Just a courtesy announcement, we are live on the internet.
And Chief Garnett, I see you've joined us. Would you like to do a quick mic test? Oh, I heard you for a second, and then you dropped out. And Paul, I see you've just joined us. Would you like to do a quick mic test?
Yes, can you hear me?
I can hear you. Thank you very much.
Very good.
Okay, this is Laura again. Can you hear me?
I can hear you now. Thank you very much.
Thank you.
And member Gaxiola, I see you've joined us as well. Would you like to do a mic test? Oh, still connecting. Yes. And Damon Silver, I see you've joined us as well. Would you like to do a mic test?
Hi, this is Damon from the Public Defender's Office.
I can see you and hear you. Thank you very much. And Sherry, I see you've joined us as well. Would you like to do a mic test?
Sure. Good afternoon. Can you hear me okay?
I can hear you. Thank you very much.
Thank you.
And Martha, I see you've joined us as well. Would you like to do a mic test?
Good afternoon. Thank you.
I can hear you. Thank you very much. Well, it looks like we're all joining in right around the same time. So I'll stop the microphone checks just so we can keep the flow going. Thank you very much.
Thanks a bunch. I appreciate it.
And Pablo, I see you have your hand raised. Is that, is there something that you had trouble with?
No, I just wanted to do a microphone and sound check.
Okay, I can hear you and I can see you. Thank you very much.
Thank you so much. Hi, guys.
Pablo, do I see a Cowboys star behind you?
Yes, you do. It's very true.
I don't want to say we're in Raider country or in, or 49er
You better
country.
not say that.
49er country. I know where I am. I was going to say this meeting's going to start with a whole different attitude.
Yeah, there you go. We're going to kick off some stuff before the meeting even starts.
Well, I'm happy to see everybody. Luke, I haven't seen you in so long. Wow, it's good to see you. All right. Well, good afternoon, everyone, and we'll get started. I know this is such a big committee that it takes folks a bit to get on, but I'm going to call our reentry network meeting for the 14th of April together to get us kicked off. I'm going to ask if the staff can begin with a roll call so we can see who's with us today.
Good afternoon. Member Lori Smith. Absent. Member Tomalinas. Absent. Member Binder. Absent. Member Zahner.
Here.
Thank you. Member Wapensky.
Present.
Member Garnett.
Present.
Member Cody. Absent. Member McClinton Brown. Absent. Member Esparza. Member O'Neill. Member Silver. Member
Present.
Silva? Thank you. Member Rosen? Present. Member Angel?
Here.
Thank you. Member Nikolai? And Member Menikachi?
Here.
Thank you. Member Terrell?
Here.
Thank you. Member Mills?
Here.
Member Dewan? Then Member Almos?
Here for Dr. Dewan.
Thank you. Member Gaxiola?
Present.
Member Fisk? Absent. Member Reagan?
Here.
Thank you. Member Marquez? Then Member Hersig? Then Member O'Brien?
Here.
Thank you. Member Amador Lebeau?
I'm here.
Member Williams? Absent. Member Yee? Absent. Member Christine Clifford?
Here.
Thank you. Member Manley? Member Manley?
I'm here.
Thank you. Member Hernandez?
Present.
Member Day?
Here.
Okay, thank you. Member Crocker Cook? Absent. Member Mukoyama? Absent. Member Vajeni?
Here.
Thank you. Member Mata? Absent. Member Tyndall? Absent. Member Halkin? Absent. Member Amanda Clifford? Absent. Member Todd Kendrick? And member, going back to Member Bender?
Hi, here. I was having some audio difficulties. Thank you. Present for the sheriff's office.
And I
Thank
see Cora Tomalinas also.
Present.
Thank you. And Chairperson Chavez?
Here.
Thank you. Madam Chair, you do have a quorum.
Excellent, excellent. Was there anybody who joined that we didn't, that joined late, whose name we didn't call? All right.
Supervisor, you didn't call my name, but I'm Paul Joseph. I'm the Assistant Chief at San Jose, and I'm here for Chief Mata.
Great. Thank you. Thanks for being here today. All right. Anyone else? All right. Seeing none, what I'm going to do now is we're going to go to public comment. And this is an opportunity to speak to an item that is not on the agenda, but within the purview of our committee. And I see 3 hands. Oh, Mary Crocker is having a hard time getting on. If I could ask the clerk to move Mary over. She's in the attendees gallery. Thank you. And we'll mark her as present as well. And then we'll give each speaker 2 minutes if the clerk could call our speakers.
Perfect. Thank you. Our first speaker is Scott Largent. I am unmuting you. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Good afternoon, everyone. Scott Largent. I was looking forward to Chief Mata, Anthony Mata, attending the meeting today, and it just kind of looks like he couldn't make it. That is frustrating. It's frustrating with a lot of the committees that the San Jose Police Department is on. I know this is just a broken record, but they have a poor attendance for all this stuff, and we need everybody at the table. I don't have to beat a dead horse too long, so I guess I'm directing this towards you, Paul Joseph. So you're a deputy chief over there, so maybe you can relay this information. The fact that the San Jose Police Department right now, we're still in the end of a pandemic. We're not out of the woods yet. The homeless are just starting to get vaccinated. We're having problems with the J&J. I experienced some really bad stuff with that. And now what we're starting to do is issue tickets that are just, I mean, this is way out of line. Tickets for unlawful lodging in a tent when elderly women are living in tents, planting flowers, and we want to criminalize that and give them a really hard time, fingerprint them, drag them out of their tents. We're doing the same thing over on Spring Street we're giving people tickets for some really lame stuff like shopping carts, small fires. Now, I'm not talking about the crackhead that's burning half of Spring Street down. I'm talking about elderly people that are trying to stay warm and cook food. Okay, there's a big difference. These tickets are, this is just uncalled for. And badge number 4822. Okay, that's just the, it's a disgrace. This officer is out there doing this, and the San Jose Police Department is sending rookie officers out to do their dirty deeds right now. You guys should be upset about this. You should be out there saying something about this. And this is just ramping up because you guys are going to run everybody through the criminal justice system rather than have actual.
Our next speaker is Robert Aguirre. I am unmuting you. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Robert Aguirre here. First of all, I'd like to say that this committee, and I think.
Hey, Robert, we're
Yeah.
having a difficult time hearing you. So let us start your time again, and maybe it'll give you an opportunity to put the phone closer or whatever you need to do.
Okay, is this any better?
A little bit.
Does this
Go
sound
ahead.
better?
Yes.
Okay. Okay, so what I was saying was that I think it's a shame that it seemed like at least half of the members of this group are not present for the meeting. And it just seems to me that this is a very important issue. And I know, Cindy, that's very important with you and several of the other members that are present. I don't want to discount your concerns, but I do want to talk about those that have either not been able to or have chosen not to be a part of this. And I think we should do something to try to get either different people showing up, or get the people that are. And I was unable to speak on her behalf. And it just seems like they're doing everything they can to railroad this woman. And by not allowing her to have somebody who's already listed as an ADA support for her, not allowing that person or those persons into the court, because I know it's happened more than once, just seems like an injustice. And when you have somebody who has difficulty understanding things and you put them in court along with the other side that has representation of a lawyer, and this person is trying to defend themselves by themselves, it's just unfair. And I see too much of this going on, and it just forces people to go further deeper into the criminal system or the whatever, the justice system. And
Next speaker is Molly M. I am unmuting you. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Good afternoon. My name is Molly McLeod, and I want to express my appreciation for the Zoom captions being on. And also, I got an email from Jess Jameson confirming that captions would be available and sending a link. I know at another meeting I went to, one of the council members had expressed how pleased they were at being able to see the captions. It's useful for all of us in many ways, because if you're a parent who's or somebody who's doing caregiving and get distracted for a moment, or you need to step away, use the restroom, whatever it is, you can come back and see what's been going on. But it enables me to participate at a greater level. And so this should be basic 101 access. And the fact that it's not consistently available at every single meeting is something that I want to raise to your attention when we're talking about more complex access issues. for education. And I just went to a very impressive, it's the second of 3 days in a conference on the Americans with Disabilities Act on the state of science. And those materials will be available. So I'll follow up sending it to the supervisors, but want to ask each of you to make a commitment for captions to always be on at every meeting that you're at, internal and external, and to add new access skills to your repertoire every week and ensure that your teams are using them. So thank you so much for your consideration.
Thank you. And those are all our public speakers. And I will just make one comment, and that is that I will be bringing a referral forward to expand to include an office of that really works with the disabled community. And we're working with some leaders. And Molly, I'll reach out to you before we bring something forward. We wanted to make sure we had more input from the community. So my hope is to do that before the June break. All right, so we're going to go to our consent calendar. On our consent calendar, we have our minutes. I also wanted to add, if my colleagues were comfortable with it, items 8 and 9 to consent. And 8 and 9, 8 is the fiscal department budget proposals, and we bring them to this committee just so you all have a chance to review them. If there are any comments that folks have on them, we don't have to put them on consent. So if anybody wants to keep that off consent, I'm happy to do that. And then our quarterly dashboard, I'd also like to put on consent. Some of the other items here are going to be pretty meaty, so that's why I was doing that. If folks are comfortable with that consent calendar, it would include items 8, 9, and 10. May I get a motion for the consent calendar?
I'll make that motion.
Oh, thanks. Welcome, Miguel. And a second from Mrs. Sparza. So we have Miguel and Maya also have joined us. So with that, I don't see any questions from my colleagues. I'm going to go to the public. I'm going to take public speakers, and then I'll come back again to confirm if there are any questions or feedback from my colleagues, and then we'll take a vote.
Madam Chair, 2 minutes for the public
Yes,
comment.
thank you.
Our first speaker is Robert Aguirre. I am unmuting you. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Robert Aguirre again. Yeah, this is on item 9, the quarterly report. I'd like to see if we could possibly include in reporting the number of people that cycle through there that are unhoused. And I think it would give us a better picture of what's going on. There's a number of people that are claiming that the unhoused are responsible for a lot of the crime that's going on. And I would like to get this kind of information to either prove or disprove that fact or claim. Anyway, I'm not going to take up a lot more time. I just would like to just make sure that we can have that kind of information collected. Thank you.
That concludes your speakers.
Thank you very much. And I think Robert raises a really good point. I think that I'll ask staff to look at how they can do that. I think that's something that we're going to actually talk a little bit more about as we move through the agenda. I have a motion and I have a second. Are there any other comments on the consent calendar? If not, I'm going to ask for a roll call vote.
Member Binder.
Aye.
Member Tomalinas.
Yes.
Member Zayner.
Aye.
Member Wapensky.
Yes.
Member Garnett.
Aye.
Member Esparza.
Yes.
Member Silver.
Yes.
Member Angel.
Yes.
Member Menakachi.
Yes.
Member Terrell.
Yes.
Member Mills.
Yes.
Member Olmos.
Yes.
Member Gaxiola.
Yes.
Member Marquez.
Yes.
Member O'Brien.
Yes.
Member LeBeau.
Yes.
Member Christine Clifford.
Yes.
Member Manley.
Yes.
Member Hernandez.
Abstain?
Member Day.
Yes.
Member Crocker Cook.
Yes.
Member Vageni.
Yes.
And Chairperson Chavez.
Yes, thank you. Before I go into our items 4, 5, and 6, 4, 5, 6, and 7, well, 6 and 7, what I wanted to do is I wanted to just have Christine Clifford make a couple of comments that I think might be helpful for those who are presenting. Christine?
Thank you. So I was reading through all these very informationally dense reports that I'm looking forward to hearing. And as I was going through them, I encountered more than 30 acronyms. So I would really appreciate it if when people are reporting out about their various areas or departments or the population that they're describing, if you would try really hard to use the full name and not the acronym. I think it would make it a lot easier for people who aren't familiar with your work to follow what it is you're trying to describe. So that's my first request. My second is, whenever possible, I'd really like to know more about how you developed your model. Are they research-based? Are they based on other successful programs that you're trying to emulate? Are they pilots that you decided to try out based on the needs of our community? How did the program and the way that it's functioning get developed? And based on what? And the third thing I'd really like to ask for is, how are you going to measure the outcomes of your programs? What do you see as success? And what else might you need to improve the success of your diversion program? So those are my 3 requests. Thank you.
Thanks. Thank you very much. And I do, Robert, I just wanted to make one point. As folks' names were being called, we actually are only missing 4 folks today. And I just wanted to be clear about that. I know it sounds like we have a lot of missing people. We have alternates and it's a little clunky, but I didn't want to give anybody the impression that we didn't have a lot of folks paying attention. In fact, we have so many people paying attention that one of my colleagues, Supervisor Ellenberg, is actually listening in. So thank you for that, Susan. All right, so we're going to go back to our presentations. We're going to go to item 4, and this is a report from the Behavioral Health Services Department relating to the jail diversion programming. And I'm going to turn it over to Sherry to let us know who's going to be guiding us through this item.
Great. Good afternoon, Chairperson Chavez and members of the Reentry Network. Sherry Terrell with Behavioral Health Services Department. And actually, Gabby Olivares, our Division Director of Criminal Justice Services with Behavioral Health, will be doing the presentation today.
Thank you.
Thanks.
Gabby, I believe you are unmuted.
Yeah.
Sorry, can you hear me now?
Yep, gotcha.
Okay, thank you. So again, I guess nobody heard that. Good afternoon, Supervisor Chavez and Reentry Network Committee members. Again, my name is Gabby Olivares, and I manage the jail diversion programs for our Behavioral Health Services Department. And I'm here to report out on some jail diversion data of individuals that we've served, our intercept model that we utilize, our service capacity, provide a brief overview of just some of our key partnerships and some recommendations. So our agenda, again, will focus on our jail diversion. Sorry, can you back up one, please? Thank you. Our report today will focus on our jail diversion data, 6 months worth of data of who we served. The intercept model, which is a SAMHSA model that we've taken and we've modified to behavioral health to show where we have access points and service capacity. We're going to identify client needs, assessment, service linkage, capacity, wait lists, empty slots, utilization of successful programs, engagement, key partnerships, collaborative programs, and recommendations that we'd like to make today for improvement and expansion. And lastly, if anybody has questions for us. Next slide, please. Okay, so I think many of you have seen this slide before. Basically, this is a chart of how we report out our jail diversion data. This is 6 months worth of data. Our reporting period is July 1st through December 31st. And we have a full array, a full continuum of services. And so if we start from my left to your right, what you will see is our outpatient modalities. So with that, we have a co-occurring program, and I won't describe every single program because I know that you've seen this before. So we have our co-occurring program for individuals that have mental health and substance abuse disorders. We have our intensive programs, which are higher rates of case management and hours spent with the client. Then we have our supportive housing program, which is a really great program that houses people and provides care. Then we have our supportive transitional empowerment team that actually goes into the jail to start working with individuals prior to release. And then moving along our continuum, we have our full service partnership. And then below, we'll describe more of the intensive programs. We have our residential and our crisis residential Muriel Wright Center, which is a program that is co-located on campus, has a 30 bed capacity for substance use and a 15-bed capacity for crisis residential, and it's on the same campus. And then our crisis stabilization, which is our Mission Street Sobering Center. So just quickly to review the numbers that we served in our co-occurring program, we served 90 individuals. In our intensive outpatient, 91 clients. In our primitive supportive housing, we received 99 referrals prior to people leaving the jail. Our supportive transitional empowerment program, we received 39 referrals. Of those 39, individuals were screened for services, but only 17 accessed the services once they left the jail. Our full service partnership, which is one of our most intensive modalities, we served 470 people. Our Muriel Wright Center, this is our residential program, served 36 people. Our Muriel Wright Crisis Residential program served 66 people. Our Mission Street Sobering Center saw 730 people. Our intensive full service partnership saw 327 people. Our assertive community treatment program saw 135. Our forensic community treatment program served 106. And our in-home team saw 170 individuals. Next slide, please. So when we first started all of our work with jail diversion, what we did is we looked at different models. And this is the intercept model. There's a lot of research backed from SAMHSA. And so this model may look a bit different. What we've done is taken our model. This was our framework when we started jail diversion in 2017. So what we've done with this model is utilized it to ensure that we have treatment access points throughout the zero intercept to the last intercept. So what I want to point out is in intercept 0, the goal of this intercept is to connect individuals to treatment prior to a behavioral health crisis. This is the earliest stage of connection prior to someone entering our criminal justice system. And so what services we provide here are in-home outreach teams, mobile crisis response. And again, it's connection before anybody enters into the jail booking, where we can provide an intervention if someone is having a crisis. Our next intersect point is number 1, which is a collaborative effort between law enforcement and behavioral health. It brings together law enforcement to respond to an individual that's having a mental health or substance abuse crisis. So here is where we utilize our emergency psychiatric PERT teams, our mobile crisis response, where someone can accompany a behavioral health clinician out to the field to make that intervention. We also utilize our pretrial services officers. More recent, we had an EPS discharge. We needed to connect someone to treatment. So our pretrial was kind enough to help us to get that person into treatment instead of being rearrested. Intercept point number 2, at this point, it's post-arrest diversion. This is the next opportunity to divert an individual from further entering into the criminal justice system. Since 2018, the Assembly Bill 1810, mental health diversion, has screened individuals for behavioral health treatment, allowing them for postponement of prosecution under diversion. And we work very closely with Superior Court, two judges that are very skilled in this area that help us divert people from further going into the criminal justice system. Intercept 3. At this intercept, individuals have already entered the criminal justice system and are in custody awaiting bail and to go to court. With our partnership with Superior Court, behavioral health is able to screen, assess, and link individuals into mental health and substance abuse treatment. To better coordinate care for individuals, we have weekly case consultations with custody health to ensure proper linkage and support when someone leaves the jail. Intercept 4, at this intercept, individuals have gone through the criminal justice system and need to transition out of custody. We have what is called our supportive transitional empowerment team, which actually will go into the jail, start working with someone prior to release, coordinate care, ensure that they have medications, and they have a discharge plan upon release into community. Intercept 5, this is the last intercept in the model. And at this point, we have individuals that are coming out of custody who have been assigned probation, court supervision, pretrial. And at this point, what we do is we work very collaboratively with our supervision agencies to ensure connection to treatment, and that supervision is provided by those officers and behavioral health jointly to help to reduce recidivism. Next slide, please. So here is what we have, the programs that we just previously reported on. We also are reporting out on the capacity, if there's a wait list or if we have empty beds available. So again, to my left, your right, you'll see the different levels of care running down: outpatient, intensive, crisis, residential, stabilization, IFSP, ACT, FACT, and our in-home support teams. And at the bottom, we have provided a legend to provide more of a definition in case you have a question about how we define our capacity. So for example, we'll take our co-occurring program. We have a total capacity to serve 106 individuals. Currently, 79 individuals are in treatment, which gives us 27 slots available. We have a wait list of 20 people. This program, the average length of stay for this program is 1 year. And so if we continue at our current referral rate, given comparison data of 2019 to this year, what we would look at is the last column, which is a projection of what we would need, what additional slots we would need to be able to serve this population. So for example, in our co-occurring program, we would need 38 more additional slots for FY21 to continue to refer at this rate. Again, I won't go through all of the programs, but another program just to perhaps highlight is our forensic assertive community team. We have 120 treatment slots. Currently, right now, we have 112 individuals in those slots. We have capacity for 8. We have a wait list of 30. And in order to continue to refer at the same rate, we would need 12 more slots. And the thing to keep in mind, capacity for us is a moving target. So every week we track our capacity, because as people are coming in to these treatment slots, people are leaving and discharging to other levels of care. So for us, this is something we do every week. So from week to week, this chart will look different for us. Next slide, please. Okay, so we just wanted to talk about some of the success rates and some of the strategies that we use to engage people in treatment. Our current success rate right now is 34%. And so what we have done is we've done a comparative analysis to also look at what other counties are doing. And so I just kind of wanted to report out, and keep in mind this 34% is overall all of our system of care, not specific to one provider. We do have providers that have higher success rates. So looking at neighboring counties, Marin County, their success rate is 13%. San Benito is 16%. And just San Diego, since they have a robust jail diversion program, their success rate is 15%. And Alameda, their success rate is 47%. So we definitely have work in this area, but we continue to look at strategies and how best to work with our consumers to quickly engage them into treatment and ensure that there's consistency and participation. So some of the strategies that I just want to quickly address for engagement is, when someone goes out into the jail, our providers, our Medi-Cal funding is considered a lockout. So what we've done, because we really recognize that in order for someone to succeed in treatment, engagement is key. And that engagement starts when someone is in custody, and you start to go in and describe services and what to expect, and you utilize peer mentors. So what we have done is we have built in funding into our contracts so that our providers can go into the jail and start that engagement process as early as possible. Unfortunately, due to COVID, we're not able to do that at this time. So I think our success rate last year was 46%. So, COVID has really impacted our ability to engage people early on into treatment. The other thing that we do is all of our new providers that are coming on board, they receive a jail clearance for their staff to start that engagement process. But again, right now we're not able to go into the jail, so we're doing window visits. The other thing is all the work that we do with our justice partners and the supportive networks that we've set up for our clients, which includes the public defender, the DA, the reentry center, Superior Court, which is key in all the work that we do. Our next strategy to continue to engage is the remote hearings and the Black Robe effect. It is very effective to have Judge Manley, Judge Silva go before our clients and praise the good work that they're doing. And these judges, they may not know it, but they actually use motivational interviewing, and that really helps with the work that we do. So we come from a very strength-based perspective. All of our providers utilize motivational interviewing, and we will be extending motivational interviewing to our pretrial services department. We have a position that we will be sharing 50% of the time, so that this behavioral health clinician can get to know pretrial, the services they provide, and start to train pretrial services officers, somewhat like you would treat a clinic, or you would train a clinician. The other thing we have infused in our programs is cultural and linguistic needs. We support all the threshold languages of Santa Clara. And if we don't have the language, we find the language through our health and hospital system. Next slide, please. So as I was saying, these key partnerships have really established our rapport with the clients and establish a better benchmark to be able to provide care and treatment. So through the established partnerships with Superior Court, Custody Health, Office of Reentry Services, Probation, Pretrial, Public Defender, DA, our community-based organizations, these partnerships have been key to keeping our people engaged and in treatment. And so I'd like to, just publicly thank all of our partnerships for all the amazing work that they've done. Alongside behavioral health, we've really done this work together in tandem. And, I think for behavioral health, all of our partners have been a great support to not just our clients, but behavioral health clinicians. So I think, just in thinking about one of the greatest challenges, I think, and I think some of our partners would agree, some of the greatest challenges that we've had is just information sharing. The criminal justice record. When someone opts in to do treatment with behavioral health, we have a really good sense of the clinical presentation and what's the level of care, but we don't always have the information, criminal justice information. So I think that's been a difficulty for us. And I think, moving forward, as we look at these business agreements and data sharing agreements, that would be very helpful to know. And one of the reasons, just so that we don't commingle our high risk to reoffend with our low risk to reoffend consumers. Okay, moving on to the next slide, please. So one of the questions that came forward was, how does the reentry center, sobering station, CAPS all work together? So our work really begins when someone is in Department 60 and 61. And I do want to highlight, through our integration efforts, we will now be supporting Department 62 and 63, which have been primarily our substance abuse courts. So a judge refers to Department 60 and 61. A behavioral health clinician screens this newly referred individual. And then if you look at the line where it says intensive mental health programs, co-occurring services, substance abuse treatment, and medication services, if you will, those are the buckets of service that we have to provide care. So looking at our medication only, this is usually somebody that's very high functioning. They just need to, take medications, and they're able to have a job, go about their normal daily functioning. So we're very lucky that in Superior Court, we actually have a psychiatrist. That linkage can happen immediately. So that's like best case scenario. So moving back up to the other service modalities, what happens is once we've assigned the level of care, the warm handoff process happens. A referral is sent to the provider contacts admin booking, and that individual is released to their care and treatment starts immediately. So can you, yeah, thank you. So the client, for whatever reason, stops participating in treatment. Then we start our outreach efforts to make sure that we can quickly engage the person back into treatment. And a lot of times when that happens, we'll leverage our partnership with pretrial, probation, state parole to help us to locate the person and engage them back into treatment. So that's a good scenario as well, when we can leverage our partnerships to connect back to treatment. If we are unsuccessful and we cannot engage the person, we highly encourage people to walk into our reentry center, where we have a whole team of clinicians there that can connect directly into any of our behavioral health services program. And what we will be doing to ensure that we're leveraging our mental health triage center and our sobering center is our clinicians will be making direct referrals to the sobering station and to the mental health triage to ensure continuity of care. And those individuals, if they connect to sobering, maybe law enforcement brings them, they come back to behavioral health for connection to treatment. Next slide, please. So part of the work that we're doing more closely lately is we have a colleague in behavioral health that is very connected to Office of Supportive Housing. So what we are doing right now is we're looking at our housing types and the here and now housing that someone needs when they leave the jail, and long-term, what would be their housing needs. So what we have here is our immediate housing needs. These were the different housing placements that we made prior to somebody leaving the jail. So when they left the jail, they had a referral to treatment and some type of housing type. So this information is from April 1st through a whole year's worth through February 28th, 2021. And so I think we've done a good job of providing an immediate housing need, but what we are looking to do is provide long-term housing. And so the other thing that I just want to highlight, that we've hired a peer support worker. His primary job will be to do the VIAT-SPDAT, connect with our housing partners, provide a list of everybody that we've VIAT-SPDATed, and get an update of where they are with housing, and ensure that that information is shared with the provider so the provider can continue to follow up on their housing. So next slide, please. So our recommendations for improvement and expansion. Again, I just really want to highlight, we want to continue to have the discussions about establishing data sharing agreements. We had a meeting yesterday. It felt very productive. So we will be collecting recidivism data. Our partners that attended that meeting was the DA's office, some of our attorneys, our independent evaluator that is helping us with our Prop 47 data pools. So we're excited that we're going to be able to start collecting that information to really know jail days, why somebody was in the jail, how long they were there, how long did it take for behavioral health to connect them back to treatment. I think the other thing that would be imperative is, when we started this work in 2017, we met pretty consistently. The reentry network met almost every 2 weeks we were meeting for a year to really discuss and plan and be mindful about what we wanted to do with this population. But as we've gotten really good about getting people out of jail, I think the next step is engaging our stakeholders of what they thought about the programs that we set up, our program utilization, and what is their recommendation from their vantage point that they see would be essential to expand these services. And also, part of treatment needs to be housing placements. We need to be able to provide treatment and housing simultaneously, and not just short-term housing strategies, but long-term. What are we going to do to successfully keep people housed and ensure that they have stable housing? One thing I just want to highlight with our Evans Lane program, what's incredibly helpful is that we have housing and treatment connected together, and someone can stay there a year if they want. Out of the programs of a success rates, that one has the highest success rate, which is 87%, because people are immediately housed, treatment starts immediately, and the clinician has a year to develop a plan of what your long-term housing plan will be. And I think the other thing that we really need to focus on is we've done a lot of great work under diversion, but the next space is really to start planning for deflection and encompassing intervention and prevention. What do we do so that these clients never touch the criminal justice system? How do we deflect from our young adults ever entering into the adult criminal justice system and further deepening into the criminal justice system? Next slide, please. Thank you. That concludes my presentation this afternoon. We are open for questions.
Thank you very much, Gabby. I'm going to go first to the public, and then if my colleagues are interested in weighing in, feel free to raise your digital hand, and if you don't know how, just wave wildly and I will find you. So we'll first go to the public.
Our first speaker is Scott Largent. I am unmuting you. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Thank you, everyone. Scott Largent. It was kind of good to hear. Well, I guess if we could call it success rates at 34%. Sounds like you guys rang off about 24 different programs. Looking over this sheet, kind of come up with the same. We need more beds. More beds, more beds, more beds, and I just don't think there's not enough out there at all. This inner step thing, when you're reading those off, the 1, 2, 3, 4, 5, the second one discussing the involvement between mental health court. I've sat and spent a lot of time, not as a patient or a client, but just as a member of the public, and also a concerned activist, I guess you could call it. A lot of my friends that I've gotten to know on the streets go in and out of Manly's courtroom, and they just cycle in and out of there. One man's been on probation with Judge Manly for 9 years. So can we say that it's not working for this man? That's where I'm very, very confused. Some people don't really need to be in Judge Manly's courtroom. They have asked to actually stand trial for their original charges. They don't want to participate in that program. I think it's outdated. I think there's a lot of people in there that really shouldn't be in there. They should be in drug rehab. They shouldn't be playing the mental health card. They shouldn't be knitting quilts and blankets and chewing candy in court, and just kind of treats them like they're, I don't want to use bad language, but I'm just not impressed. It's an outdated program. I'm looking forward to when Judge Manley retires. Well, he actually did retire. He's on assignment, but I think it's outdated. We need some type of homeless court. We need new blood in there. And the team is just not pulling through anymore. Look at the streets right now, folks. You guys know it. Thank you.
Our next speaker is Robert Aguirre. I am unmuting you. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Robert Aguirre again. So, like what Scott was saying, that the way the system works right now might work for a lot of people, but there are some people that just don't quite fit into these categories, and they're kind of like you don't really know whether it goes in this bucket or that bucket, so you just kind of flip a coin and decide where it's going to go. And I know of one particular case for somebody who's trying to find permanent supportive housing in Campbell, and the city of Campbell has come against her with full force, and I believe is trying to put her into conservatorship. And she doesn't need that. She doesn't need to go through mental health. She's already gone through that process. They've determined that there's really nothing wrong with her. She's very stubborn because of the things that she wants to do. And because we're not supposed to reveal names or anything like that, I'm not going to reveal her name, but we've been following her case for quite some time. And the city of Campbell is just coming against her full force. And wherever she goes, they're telling her she can't be there. She's claiming through CDC regulations that she can't move from where she is. She's supposed to stay where she is. But they can insist on getting her out of there by creating all these stay away orders to get her to get further and further away from where she wants to be, where she needs to be, and where she's providing a service for people. And I think the county, if they really want to help this woman, they could do a lot more than just shuffle her around from place to place. She really means well and tries to do the right thing for people. And I don't think this court system that you have set up here is designed for someone like her. She's not using any drugs. She doesn't use alcohol. She's the only thing I can say about her is she's stubborn, and that's it.
That concludes our speakers, Madam Chair.
Thank you very much. And I'll start with Mary.
Hi again, Ms. Gabby. I am struck by your utilization and how many of the highest numbers seem to be for acute mental health illness. And I'm saying that in terms of crisis residential use. And I'm wondering what's happening with the medication dispensing in incarceration settings. Like, are people coming out with their psychiatric issues stabilized, or are people still not receiving the medications they would need for stabilization prior to discharge? If you know.
I think probably, I don't know if we have any colleagues from custody health. I think they perhaps would be the best individuals to address that. I know that when we do our coordination and discharge process, we do take the consumer, to receive their medication. So as far as I know, everybody that we're working with, it's essential, or programs will not take our consumers without their medication. So I know that our provider does do the inReach. We coordinate all the discharge, and immediately upon release, we take the client to pick up their medications.
Okay, because I just wondered about their level of stabilization prior to discharge, that they would still need that acute level of care. It's like, wow.
Dr. Day, do you want to give a perspective on that?
Sure. And the medications, although, the patients all leave with medications. These are planned discharges, so the medications are in hand. And like Gabby said, oftentimes they will take the patient directly to pick up their medications and fill those scripts. The patient's diagnosis, however, stays the same. And there are patients that, basically their diagnosis is an acute diagnosis. And the medication is basically a part of their treatment course that will have to remain the same. Any variation in the medication regime post-discharge will basically have that patient spiraling back and decompensate. And so it may be part of this, just their diagnosis. And because, their diagnosis will consider them to be fairly, high risk and or, seriously mentally ill. But the patients these are all planned discharges. The medications are in hand when they leave, and or Gabby's team takes and gets the medication.
Thank you.
And I just, sorry, just wanted to say one last thing is we case consult with Dr. Day's team twice a week, especially for people that are very high risk and we have more concern of their discharge process. So we've implemented that. I think we've been doing it almost a year now with our diversion cases, especially that people that are very fragile and we know have a hard time acclimating back. We've initiated our AB 1810 manager, Miss Robin Daniels, coordinates that with adult custody health twice a week. And I think that's been incredibly helpful because as you can imagine, the clinical presentation is very different when someone travels through the court, when they go back to jail and then they release back into community. A lot can happen from, that presentation in court to going back into custody. And I think the other thing that's been, difficult is we're not in the court. So a lot of our work is being done, remotely, and our screening process is now done over the phone. So we actually do rely on custody health a lot. And we message them all the time and we'll say, like, can you go check on this patient? They wouldn't come to the window today. I couldn't see them. Can you, give me some information? When's their next psychiatric appointment? So, I have to say we've relied a lot lately on our adult custody health partners to help us to provide more updated clinical information since we're not able to see the clients anymore.
Thank you. Damon and then Christine.
Yeah, Gabby, just a quick question. I think probably all of us love that idea of a deflection model, and obviously kind of dovetails with the no entry model that I know Supervisor Chavez has mentioned in the past. But my question is there a model for seeking input from either the consumers, the clients, or the client family members of what a deflection model could look like? In essence, what kind of services would have helped avoid them entering into the system in the first place? Because I think one of the things we're learning across the board, certainly from the public defender perspective, is trying not to arrive with solutions for the community without first figuring out from the community's perspective what they really need when we arrive on scene. So I was wondering if there's a way to collect that information, knowing that self-reflection probably is challenging in some ways with this population. And so how you gather that information and make it constructive is probably a challenge.
I mean, I think that's an excellent idea, especially since so many families reach out to us, right? Their child is back into custody. We work really closely with NAMI. Right now we've been having some community stakeholder meetings. So, if we decide that we want to go down this path, I would actually expect that we involve family and consumers. And one thing that, family members always tell me, like the incredible stress it just causes on the family unit. And so, there's a lot of research lately and presentations and trainings you can go to on compassion fatigue and how to deal with a family member that's just cycling in and out and you're not able to connect them. So, of course, this will require further discussion, but I love that suggestion because a lot of the referrals actually come through family. And a lot of people call, how can I have this person like walk into reentry center? And we're not right now, again, because we're not presently at the court, what we're doing is people are just calling us. And we do have luckily staff at the reentry center, so we're having more walk-ins. So you know, whatever we decide, I hope, given your suggestion, that it's highly considered. You really do need family and consumers at the table. And really, I think we've done a great job of getting people out of custody, but we need to hear more from the consumer. What else would be beneficial and helpful? And, you know, we've heard housing. What types of housing? You know, the other thing we've heard a lot about is just meaningful activity. I was in the jail for so long, like, I'm so tired of program. What do I do now? So I think even just discussion about successful integration, what does that mean? And what does meaningful activity mean for our consumers? What can we do to provide that meaningful activity if maybe they're still stabilizing on medication and they're not ready to go back out into the workforce? What other meaningful activities can we provide them? So thank you, Damien. I hope you will participate in our discussions.
You know, one thing that I'm sure you all are watching is that Supervisor Ellenberg is kicking off a series of discussions as well. And, you know, as part of the alternatives to jail. So I hope that's something that you all are actively participating in. And I think you can reach out to her office to see when these convenings are. And then the other is that NAMI is such a great partner in terms of pulling together parents and consumers. They will do, I found them to be very, very, very collaborative. Christine?
Supervisor Chavez, before we move on to the next question, could I just add that, you know, I think a lot of the feedback in response to Damon's comment also came through our work with the community around community mobile response. So the idea was really, how do we think about deflection, so to speak, or ways of creating opportunities in the community that actually truly defer individuals away from law enforcement engagement. And, you know, much of the response and recommendations were, to Gabby's point, a true involvement of family members from the onset. So even when an initial crisis is emerging or something's happening where someone has a need, truly you need to have that, you know, family engagement and connection from the onset. The other pieces were about how do we ensure that those that are coming out to the community or engaging with someone who's encountering a crisis truly understands how to de-escalate that situation, provide support in a more healing, trauma-informed way, and creating that engagement at the onset of that situation such that supports and services are being offered. So I think if we were to be able to bring a lot of that feedback, many of the participants who gave public comment during those opportunities were individuals whose family members became involved in with law enforcement, were incarcerated as a result of a circumstance happening to them or their families. So I think there's a lot that can be learned from that feedback that we've gathered thus far.
That's helpful. Thank you. Christine?
Yeah, I was just wondering, we have such a large population of people that are in and out of the jail in 24 hours, or you're moving more towards trying to do cite and release in the field rather than bring people in at all. How are services and needs assessment provided for that population?
So I think somebody from custody, if they can address that, I wouldn't have that information about those rapid releases.
Yeah, I mean, I would just say, I think the short answer to that, Christine, is that we don't have a handle on that. I mean, that's just my own perspective. And I think part of the reason, and I can ask Sheriff Binder, or if San Jose PD wants to respond to this, that I think what we have been giving people are little cards that say, you know, here's where you can get service X, Y, or Z. But I think we haven't really done quite enough to deal with the cite and release group. Now, I know we need to get there. I think that as we refine this core program, I think it's going to allow us to build what we need to build for these more, these more casual interactions. And the other problem, just to say this, is that I think the number of people that are cited and released in a year countywide, and Sheriff Bender could help me if I'm wrong about this, but I think it may be upwards of 60,000. And so I think the other issue we have to think about is, how do you properly prioritize where we put the next pot of resources? And as an example to that is that the district attorney's office has been working really closely to look at that engagement for people who have had 1, 2, or 3 interactions relative to drugs. They don't, they're not going to pursue them, but when they get to a certain number, they're going to be more aggressive. I think one of the things we need to think about is whether or not there's an intersection there. And then the other thing I'll just say is that as part of the Children's Families Seniors Committee and in our work, I think with Sherry's department and a number of other departments, I think we have to get way upstream as it relates to how we address mental health issues, period, early in life, so that we're dealing with many fewer people who, I think this goes back to the point about deflection. Like, I think there's some points that we're going to have to really drill down to. But I think you asked a great question, Christine. I don't think we're there yet. Matt?
Yes, just very quickly to Christine's and Damon's keen observations. Steve Preminger, the CEO, and then Angela Shane, Social Services, introduced me to a group when it was just starting to take shape, but now the pace has really picked up. It's usually Monday afternoons, and it's Bridge to Recovery. I don't know if it's properly called a consortium, a group, or a network, but it's academia, industry, and government, mostly CBOs, and basically sharing what array of services they provide, when, to whom, and how. And I think at this stage, really starting to sort out what's the best way to economize and deliver those services. So if anybody is interested in that, you can email me and I can give you a link so you know how to get involved. But I think they can really help to get the right services to the right people at that deflection stage a lot sooner than maybe some of the other things that we have set up.
Thanks, Matt. Erin, and then I'll go to Cora. I see you, Cora.
So as we're kind of looking at deflection, and I think we probably should be looking at it anyway, it has been a long time since we've seen the data on what are the charges that are bringing these mentally ill and substance abusing folks into jail in the first place. And so kind of looking, so kind of looking at that, are we bringing the right people in, and are we serving them in the right kind of way? Because one of the questions I had as I went through the entire packet was kind of, who are we deciding goes to EPS, who goes into jail, who goes into the sobering center, and who gets cited and released? And I think it would be really interesting to kind of get information on those two aspects of it. And because I think the deflection is where we all want to get. And we also need to be cognizant that we don't want to create a system where people have to fail up to get the care that they need.
Yeah, thank you for that, Erin. Cora?
I'd like to thank Damon for that comment regarding the family and the community, because for a long time, because the funding was geared to just the client, we were not hearing what you all are doing regarding the family in tandem, the services being parallel to the client themselves. So I think each time that we make a presentation, especially to the community, we need to call out those services the same way we do with the client services and all our programming. That's all. Thanks.
Thanks, Cora. So I don't see any other hands up from my colleagues. Oh, Judge Manley, sorry about that.
Thank you. I just have one question relating to substance abuse. In your listing of the different modalities of treatment. Now, I may have missed it, but I did not see detoxification. Medical detox, we receive so many requests, particularly when we're talking to people out in the programs in the community. Case managers will ask, can't you place this person or the person into detox because they're using daily, they're getting no benefit from mental health treatment, and we just don't know what to do. And the answer is not to put them in jail, in my view. So I just wondered, do we have a list of the number of beds for detox that we have, the services that are available for immediate referral, so that the people out in the community can make those referrals?
Judge, I can connect with my substance abuse colleagues and provide you that list.
Okay, because it seems to me to be pretty much non-existent.
Yeah, I mean, I think Judge Manley, again, just to be kind of blunt, we have detox beds, and some of them, one of them was on the slide, I think Muriel, right? And we have a couple of other locations that have detox beds, and I forgot what the total number is that we have. And one thing I will say too, really, just even as we're having this conversation, that all of the behavioral health services are in one agency now. And that the benefit of that is that what we hope is that we're going to break down those silos even more than I think that we have to date, but we're getting in that direction. We don't have medical detox. We have detox. And one of, and I'll just mention this since Miguel is with us, as is John Mills, that I think one of the areas that we had that the county had been investigating some years ago was whether or not we could and should invest in medical detox in our healthcare system, because medical detox really requires, I mean, there are ranges of it, and but one of them is that which really requires people to be hospitalized, so for their safety. So what I would just say is, Miguel, as we're having the bigger conversation around the emerging need for additional types of beds, that we should add the medical detox to that discussion list that we've been having and that you all have been having internally as it relates to the healthcare system. Judge Manley?
Now, I was just going to make one other comment, and that is that, and I think it's borne out in this report, that we really have to do a better job on finding the right housing for people, and to make the services available or the treatment available. I know we know how many slots there are, how many are filled, and then there's always a waiting list. And my concern is that the waiting list in jail now is going up. It's gone up dramatically. We have more than 60 people, or we had 60 this morning, awaiting release. And I think what that reflects is we just either don't have the treatment in place, the housing in place, or we don't have the ability to quickly move people. And that is one of the reasons I like deflection, because then we don't ever have to get into this issue except for a very limited number of individuals. But it is a concern that it just appears to us that we don't have sufficient treatment and housing for the number of people that get referred.
Right. And Matt, did you want to jump in again?
Well, I'd like to appreciate Aaron O'Brien's inquiry, so it would be to that. I don't want to cut into Judge Manley's part.
Oh, no, I think Judge Manley, were you done? Okay, go ahead, Matt. I wanted to respond to Judge Manley, but I wanted to wait till till everybody had spoken. Thanks, Matt.
Okay, well, ever so quickly, we've seen a lot of progress with regard to proportionately more people being cited in the field and at the jail after booking, and less 647Fs, the drunken pedestrian charge, which was a big portion of those. There's also progress to be made with that category. and it's in our citation policy. We can apply that. And I think it's really important that we make everybody aware of what services are available at the reentry triage center. It's a lot more than was available before, and it's very convenient. So I think that'll be helpful, but the deflection efforts, hopefully, and if they don't qualify for that, the expansion of diversion will help. So that's for Aaron.
Thank you. Sylvia?
So I wanted to just say that, I mean, I think everybody agrees that the housing issue is key and center to, providing a lot of the services that the county offers. And without the housing, we just can't do it. I mean, just in the law, in the legal profession, our attorneys struggle very much in serving the unhoused clients that we have, just in the basic context. One of the things that has come up with this conversation is that on the one hand, we have families who may be exhausted, but who continue to care for some of our clients. And they just do not have the resources, the bandwidth, the information, or the support to be able to provide support and perhaps even housing for their loved ones. And that we have to think outside the box in terms of how we address the housing for our mentally ill clients, because the reality is, and unless I'm wrong, and Miguel can chime in on this, but no matter how resourceful our county is, and no matter how much money we or desire we have to build, we will never be able to fulfill the demand for housing in terms of having the county being the one to provide. And I think we all have to be realistic and pragmatic in terms of what this call for housing means, and what expectations we can reasonably have for the county to offer. And so I just offer that there's a connection in terms of, could we reach out to and ensure that the clients that we're serving, maybe they have a family member, maybe they have others who are willing to take them in and support them and help them with either funding support or more resources to help them. But I just wanted to throw that out there because it is a common theme, and it is a common issue that we see in all the conversations that we have in terms of how we address the services for the mentally ill.
So thank you all. That was a very thoughtful discussion. We have about 3 more items on our agenda, so I'm gonna move just kind of move us to the next item. I do want to just say to the staff, I'm remembering the first time we had a discussion about these items and how little information we even had about our own services. And I just want to appreciate the work that went into, moving us as far as we've come. A couple of observations that I want to make, and one is going back to the point that was raised earlier by Christine, is that I am very interested in understanding how we think about the intercept model in terms of which model we're using, why we're using it, and really being able to assess the success of it. And I know my staff has been interested in the sequential intercept model, and I'm interested in knowing, along with that model, whether or not there are additional changes or tweaks that we can make to really increase our success rates. And I think one thing I'd like to recommend is that as part of the next jail reform study session we have, Sherry, this might be a really good opportunity to just introduce the intercept model to the full board and help the board understand the context that the context of the development, and it's how you're going to be evaluating it in the future.
Sure, we can do that, Supervisor.
And then the other thing, you know, I do just want to add a point that Sylvia raised that I'd forgotten, is that I have wanted the county to invest in a family finding unit that could help across program areas engage families. And I think the point you raised, Sylvia, about the fact that we do have so many families that are still really interested in trying to figure out how to help their kids, and we're not helping them stay in place with families that actually really can support and care about them, I think is such a missed opportunity. And we've been expanding the program of family finding in our foster care environment, but I actually think it should be applied to this area. And frankly, I actually thought we were already doing that. So I'll just say to my staff, I think as part of budget, we're going to need to take out whatever old referral we had on family finding and re-put it into the program. Because in fact, I will say too that both Pablo and Amanda Clifford have given us feedback on this board about how to make it easier to support families as they're trying to support loved ones who have very serious challenges. So I'll figure out a way to reintroduce that. This is the next question I have is really more for Miguel and Councilmember Esparza. This might be an opportunity. I know you've been thinking about some strategies as well. But as we look at the level of care wait list, and I'm on packet page 18, we can't, our staff is helping us really anticipate what our needs are in the future. And one of the questions that I'm really going to be interested in as we go through the budget process is to better understand the strategies we're going to use to expand these services. And I think that this speaks to kind of an additional issue, which is that we have our housing team, we have our drug and alcohol team, we have our mental health services team, and we have our public safety and justice team. And I am really interested in getting these teams together to take a look at the bed needs, because what's so wonderful about the staff information is it actually answers the question that we've been asking for a while, which is, where do we see that on the continuum of care we don't have we can't respond to the need properly? And then, obviously this goes back to the point, Aaron, that you raised about, and then therefore, what are people getting arrested for and how are we placing them? So in any case, Miguel, this particular packet page 18 is one that I think we ought to have a discussion in budget. Even if the answer is we're going to be doing it incrementally, I think we have to really be able to respond to what we see the need is, what part of that need we're going to be able to meet and how, what part of that need can't we meet and why and why not. And then Maya, this might be an opportunity to just weigh in with your thinking on this as well.
Thank you. Thanks, Cindy. We've been talking about this for a while, and I think I would love the opportunity. I love what you just said about bringing the teams together to see how the city could really contribute. You're the system and the experts in the system, but with COVID and the resources that we might have with reimagining a lot of the different things that we're working on as a city, I would love to see how we could how we could contribute to that effort, because I was really taken by the number of slots needed in fiscal year 21, all down the board. And I think that this is all of us, and I think we should all contribute, and I think the city is seriously interested in doing that.
Yeah, thank you very much. So with that, thanks. This was a really, really thorough report, and I appreciated, Gabby, when you gave it, you used very few acronyms as you were speaking, and I want to say thank you for that. That helps all of us both stay engaged and understand follow-up. So with that, we're going to move to the next item, and that item is item 5. And this item, I think Javier is going to present this item. This is a report relating to the CAPS program. And this is the community. Okay.
Awaiting Placement Supervision Program.
Yeah, I was just looking for Christine so I could read it properly and say what it is. But we'll turn it right over to you, Javier.
Thank you. And I promise I'll use maybe less than 5 acronyms in my reports. So, so the Community Awaiting Placement Supervision CAPS program evolved from a multidisciplinary team effort to expedite process to release individuals from custody placed on the Jail Assessment Coordinator, the JAC list. And I think to Christine's earlier question about how it got developed, well, I think I recall, Judge Manley asking Gary Hersick and I to his chambers to develop a process back in 2017. And so we created that process to assist to reduce the number of individuals on the JAC list. I think at a high point, we had about 130 or 150 people on the JAC list. As of today, there's 61. Of those 61, 20 individuals were just placed in the last 2 days. So we're making huge inroads to reduce the number of folks that are waiting in custody, order for treatment and release to services. So this process started on April 17th of 2017, and then it was morphed into a program on July 2019. So in your packet, we identified the number of enrolled clients between July 2019 and March 1st of 2021, that was 121 clients. And then if we look at the 6 months of July through December of 2020, 14 of those clients were enrolled, 7 were successful and 7 failed. And those failures were due to non-compliance with probation terms. Only 3 were due to new law violations and 1 due to a bench warrant. And so, back to Christine's question about the successes. So we have a administrative policy and procedures document that was developed by, in collaboration with behavioral health, custody health, probation, pretrial, Office of the Sheriff, Department of Correction, and the Office of Board of Housing. And we listed specifically the indicators of success for the clients and the indicator of success for staff. And for the client, we want to make sure that they were enrolled in treatment, attended the required court cases, were complying with a treatment program, completed a treatment plan, and was assessed and screened, and then linked with a community worker here at the reentry center or with the client navigator. And of course, complying with probation, parole, or pretrial reporting requirements. And right now, I think we have about 4 individuals on our caseload, which is low, and that is due to Prop 47. So behavioral health created the Prop 47, and a lot of clients are now immediately engaged and enrolled in Prop 47 as opposed to being released under CAPS. One of the benefits of CAPS is the warm handoff. So literally a deputy correctional officer will bring the individual on Wednesday morning from main jail, walk them over to the reentry center, and we have a team to engage with the client and then with the probation officer. And I want to commend our probation department because they've identified key and very strong probation officers to work with this clientele, but most importantly, to work with our partners. And at the last board meeting, I did let folks know that the Deputy Probation Officer, David Akers, who worked with CAPS from early on, retired, but probation did place another exceptional PO that was from the drug treatment court that's now working on our CAPS caseload. In regards to the family finding question that has come up earlier in this meeting, we have a partnership with the Ombuds program with the Office of Human Relations. So we created a process where during intake, so prior to COVID, my staff would go into custody and work with the CAPS client about 2 weeks before, and we would ask them if they want to be engaged, receive outside support for family finding. And we gave them the forms, and it would be the Ombuds staff to support those clients. Since then, we haven't been able to go back into custody, but when the client comes here, we do offer that opportunity to access the Ombuds program for family finding. But I think it's important to note that we expect, and depend on all of the service navigators, the case program, the treatment programs to work with the clients to engage the clients with their families. And just lastly, one of the benefits of the client coming to the Reentry Resource Center upon release is that we just recently brought on board 2 community workers with lived experience that are also connecting with the individual. And then our existing community worker, we work with San Jose State University peer navigation contract to ensure that the client has a cell phone, so they could connect with services that we offer, and most importantly, connect with probation and parole. And then lastly, just to identify where CAPS fall under the sequential model, and I think it would fall under Intercept 3, the jail and courts, because the individual is already in custody and are being connected with the court system. That concludes my presentation. I'm here to answer any questions.
Great. I'm going to go to the public first, and then I'll come back to my colleagues.
First speaker is Scott Largent. I am unmuting you. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Okay, good afternoon, everybody. Sorry if I sound kind of all over the place, trying to grocery shop and attend meetings at the same time.
Scott, we can't hear you. Scott?
It appears that we've lost Scott, Madam Chair.
Okay. If he calls back in, let me know. Are there any of my colleagues who have any questions on this item? I don't see any. Okay, well, there's no, I think I think that maybe this is another one that we can put under the jail diversion program report as well. I think that would be helpful. And thanks, Javier, for giving us that update. And one request I would make is just off agenda. I'd be really interested in what the role of the ombudsperson is and their organization in terms of family finding. How often are we really asking for their help, and how often do our clients ask for their help? I'm just curious about the utilization.
Sure, absolutely, we could provide that.
Great. Oh, Scott's back again. Let's see if he's.
Our next speaker is Scott. You have 2 minutes to speak. The timer will start when you begin speaking.
Thank you. I really do appreciate that, Cindy. With headphones and pushing a shopping cart, so I do apologize. Need to pay a little more attention. I enjoy the report. I kind of said that before. I enjoy hearing, what's going on in different departments. I'm not trying to get off topic. We've talked a lot about family, community involvement. No matter what item we're talking about, that is not involved. And I get frustrated when I'm on a lot of this stuff because 6 years ago, I'm coming on almost 6 years, my family flooded the system. My friends flooded the system. My grandma flooded the system. They kept asking, what do we do? How do we get more help? How do we get better detox? How do we get them into, how? We don't know what to do. And I really enjoyed what you had to say, Sylvia. You knocked it out of the park. And I'm wondering why we don't involve family. My family, they're actually wealthy and they're out of Monte Sereno. And of course, I understand the bridge got burned. I was a meth addict. There was all these problems and stuff like that. They would have probably written a check to you guys to put me in rehab. They would have, it's not put the money in Scott's hands, it's put it in the hands of the system that's going to help him. Like, here's the path, because I don't get along with them. You're butting heads nonstop with everybody, but they would have more likely paid for it. And of course, I wouldn't have been your problem. I just don't understand. They reached out so much. They called so much. And when I threw in the towel, I would have signed on that dotted line. I would have gone somewhere for 6 months to a year. I would have done whatever it takes, because the golden ticket was my child and being in her life and the reason I got sober. I still have a destroyed family relationship right now. They still don't believe me that the system does not work. And I still do not have drug treatment.
That concludes our speakers.
Thank you, Scott. We're going to go to item 6, and this is a report from the Office of Reentry Services relating to the Mission Street Sobering Center and Mental Health and Drug Triage Center. And Javier, is this you again?
Yes, this is me, and I'm going to be sharing my screen with you all. So if you just bear with me for a second. There we go. So I'm just going to bring the our PowerPoint presentation that's in your packet. Can everyone see the PowerPoint presentation?
Yes.
Okay, great. All right, here we go. Okay, so on behalf of the behavioral health team, whole person care team, and EMS and other partners, I'm very pleased to present to the Reentry Network our progress on the Mission Street Sobering and Mental Health Drug Triage Center. Putting this legislative file together was a difficult task, but I think it was an opportunity for us to just showcase all the data and the outcomes that we've been able to produce since we first opened the center back in October of 2017. So looking at the data over 3 years, so this is between October of 2017 through March of 2021, there was almost 2,500 individuals that were brought into the center. That was equals to almost 1,500 unique individuals. And as you can see, the numbers, it started low in 2021 and 2017, and it has been increasing over time. And you could also see on this slide the volume between law enforcement, behavioral health, which is mostly folks come from EPS, custody, individuals that are being released directly from jail, and our emergency departments. So the majority of the clients that were admitted were referred by the law enforcement agencies. So in your packet, there's a history of how when law enforcement agencies were onboarded or started using the center. So as a pilot project, we first started with the Police Department of Mountain View and Campbell and the Office of the Sheriff. And so, and then over time, other agencies started using the center, and then San Jose Police Department started using the center in late 2018. And then the second number of individuals that are coming from behavioral health. So that's from our emergency psychiatry services from EPS that are brought in, and mostly those individuals are brought in by law enforcement agencies at EPS, and then EPS and contacts the Sobering Center Mission, the mental health drug triage, to see if there's capacity for those individuals to be transported. And then the Sobering Center staff will pick that individual from EPS. And then about 17% of those clients were referred by the emergency departments. We also wanted to share with you the race and ethnicity makeup of the clientele. The majority are 36 to 50 years old, majority male, and Hispanic Latino make up 34%. So we started looking at in terms of relation to the jail population. So like, for example, the Hispanic Latino make up 25% of the county population. They make up about 55% of the jail population, but only about 34% of the Sobern Center clientele. The non-Hispanic white, they make up the population about, the county's population is about 30%. In jail, they make up about 23%. And here at the Sobern Center, about 29%. So it's something for us to consider of how we need to increase the outreach to our law enforcement agencies and all of our partners to also make sure that all populations are well represented in using the center. And then in terms of the admissions to the Mission Street's Sobern Center, and 64% are related to being publicly intoxicated. And then that's followed by 34% having a mental health or under the influence of drugs. And one thing to note on this, in your packet in figure 4, we also showed the public intoxication, the number of folks that are being arrested under 647F, something that Matt Fisk mentioned earlier, and that's decreased significantly since February of 2020. And perhaps that's due to COVID limiting a lot of the capacity of establishments in the public. So I think as things reopen, we'll probably be monitoring if we're going to see an increase in public intoxication and 647 arrests. Wanted to take a closer look at the referrals from our largest law enforcement agency, San Jose Police Department. And we've been working with the captains and the chiefs in terms of increasing utilization of the center. It hasn't met the expectation we had early on for San Jose PD being the largest in the county. But we are monitoring the numbers, and I believe the reason why the numbers were low is when we did first the outreach to San Jose PD, a lot of the officers were really looking for a place to bring individuals that having a mental health crisis or under the influence of drugs. So we brought that component to the Sobern Center in March of last year, which then saw an increase of utilization from San Jose police officers. And so right now we're working closely with San Jose PD to engage officers, and once it's safely to do in-person briefings, we're ready to do those in-person briefings with law enforcement agencies. So the top 5 law enforcement agencies for the last 3 years consists of Mountain View, followed by San Jose, Campbell, the Office of the Sheriff, and Palo Alto. So again, here you see we looked at just the month of March of this year in terms of the admission. So as you can see, mental health triage was 48, followed by drug triage at 27, and then 25 for sobering services. So EPS is our #1 referral agency of bringing individuals into the Sobern Center. So we looked at the services and benefits. So I think this slide does show the great linkages that the Sobern Center staff has made on behalf of the clients, in particular to enroll individuals in the whole person care, also enrolling clients into behavioral health treatment, and then and also offering a longer stay for individuals to stabilize. So initially we were had about a 6 or 7 hour stay, and now we're getting close to 12-hour minimum stay for an individual here at the Sobern Center, keeping in mind that they cannot stay here past 23 hours, 59 minutes. And then one thing that we also looked at is how many individuals did we divert from ever being booked into custody. And so of the 2,500 visits, 970 individuals that were referred by law enforcement agencies. So instead of them being booked into custody, were brought in to the center. And then lastly, in terms of recommendations for improvement, here's the list of the items that the Sobering Center team, the task force, is working closely with Horizons, who's a provider of the services. And I think one key component is for us is renaming the center to broaden beyond sobering services. When we reached out to recently to a team from San Jose Police Department, when you think about Mission Street Sobering Center, it's all about sobering services, but we've added the mental health and drug triage unit. So we're kind of looking at renaming the center, also updating our brochure and a shorter video that we could share with law enforcement agencies to increase capacity. And then lastly, something that was mentioned early, and I think one thing that I'll make sure that when we report back on this is we include family findings. So the Sober Center staff will talk to the individual about reconnecting them with their family, specifically if someone's going to pick them up. But also they've had successful connections with the family members to then not only just pick them up, but then to take them to other treatment services. And then once they're connected to whole person care, there's wraparound services for that individual. So with that, I'm open for questions.
I'm going to go to the public and then I'll come back to my colleagues here.
Our next speaker is Scott Largent. I am unmuting you. Please accept the unmute. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Thank you. Good afternoon, everyone. Scott Largent. As far as the sobering station, seeing people go in there now when they're being dropped off by the different agencies is really neat to see. I must say, sometimes I park my van right near there. I don't want to be completely rude and film the whole interaction. I try to keep at a distance. Sometimes I don't even film. And I just watch what happens. And seeing the compassion of the officer helping the person, kind of getting them up the stairs there with their belongings. And it's really, really neat to see. The harder part is seeing when the person gets out in less than 24 hours out that other door, and they're right back out into the elements. They're right back over there at St. James Park, or, what I call, Lord of the Flies down there at the crash zone. Is there a way when most of these people, and I film hundreds of them, I think that they should be put on longer holds. Some of the bizarre behavior that's happening when they're going through these meth-induced psychoses, I think would warrant that. Now we're trying to help them by not charging them with other crimes and throwing them into the jail. But just by letting them back out, I just don't think it's really helping them. How do we put them on a 2-week hold? I think a 2-week hold would be appropriate. Person could get showered up, cleaned up, stabilized, maybe back on their meds. Maybe you guys could actually reach out and kind of get that bond going between the family. You can't do that in 24 hours. And 6 years ago when I dealt through that, of course, there wasn't anything in place like that. I spent the night in the sheriff's department bathroom because it was the only warm place in town. And Bad Boys Bail Bonds made a couple phone calls for me. And basically everything after that, you guys know the story from there. I think we're listening, but let's start involving the family, like really start involving the family. I think it would help out a lot, and it would save us a lot of time, money, and frustration. Thank you.
That concludes our speakers.
Thank you. I'll go to Laura Garnett and then to Aaron.
Yeah, hi. Thank you for that, Javier. So I'm just wondering, like when we're talking about family finding for adults, I want to just say what I think family finding is and why I think it's really different for adults than it is for youth. When we do family finding for foster youth, we're looking for families often that the youth has never even met. So it's often apparent that the youth never knew. Families could be in, different state, and so it's truly family finding, like discovery. I feel like with the adult population, there absolutely could be some of that, but I think it's more honestly obvious. I mean, I think the family, for the most part, as Mr. Largent just talked about multiple times, is often there and is not allowing their young adult home for a variety of reasons, or their older adult, whatever. So I just wonder if we're just using the wrong language, if it's not family finding, but family strengthening, family reunification. Like, what services do you need for this adult to live in your home and be successful? Just like we do with kids. I don't know why it's any different with adults. It's the same exact question. What do we need to support you and your family to have this person in your home? Because that's where they belong, not in a jail, not in a residential bed. If we can do it safely, they belong at home, if somebody is willing to do that.
Yeah, Laura, I really appreciate that. Let me say that one of the reasons I was so interested in actual family finding for the reentry center is that one of the things that I learned is we've been dealing more and more with young adults who have behavioral health issues or mental health issues, that sometimes we have young people here whose family has been disconnected from them because they've been on a just really disconnected from reality or whatever for sometimes for years. And one of the things that I learned through NAMI is that you could have a family who doesn't even know their young adult human is here in Santa Clara County, and that's one component of it. I think the other point that you raised that I think is really right, and this is one of the areas that both Pablo and Amanda mentioned, is that we talked a little bit about what happens when someone comes out of custody, and they made a recommendation that I thought was really rock solid, which is that for some families, actually taking the person in has a financial cost, whether that's for food or because they're renting 2 rooms in a home, and that with a little bit of rent money, that person could come in and not be an additional burden to a family that's already being kind of pulled down. So one of the reasons I was so interested in us digging into this is that I think for generations, historically, public policy was rooted in this idea that there were good and bad actors, right? And so if a parent was a bad actor and couldn't handle their family, we took their kids. And if an adult was a bad actor, so, and in fact, some of our policies say that you can't get housing. Like, we don't house some families if they have an adult child, a child over the age of 16 that's male. And if you think about the idea that our job is really to support, I think we have to rethink the whole thing. So I totally agree with you. And I think I'm using that term to mean something much broader. And it's probably worth us just looking at that. I mean, just having a discussion about that. I actually think too, as we're thinking about equity, that so many of the racist policies that we put in place are rooted in the judgment of one over the value of another. And so, you're right, Laura, it's probably worth a much bigger discussion. And I'll work with Javier and Miguel and Maya on my team to figure out how to shape that up for a discussion for reentry.
And can I just say one more thing?
Yeah,
I
please.
just feel like we have like the perfect voices on this committee. I mean, they're the same voices that were on the Blue Ribbon Task Force. And we have the answers like right here on this committee with the people we have. I mean, we've got like some of the best input I've ever heard. So yeah, I would love to have a broader discussion about this.
Yeah, and the other thing, and I'm sorry that Kathy Forward isn't on the committee anymore. And I know we have somebody from NAMI, but I do think it might be even valuable to, just because Kathy's been doing this a long time, to get some folks who had been helping us maybe be part of that discussion. So thanks for that, Laura. I appreciate you shaking me there in a good way. Erin, and then Paul.
So I want to, from the program side, confirm what both of you are saying. I mean, a whole lot of it is reconnecting, because we have people who have just dropped out and disappeared. And so reconnecting family, but a lot of the time bridges have been burnt. And it really is about working with families to rebuild that relationship so that they can be there to support one another. Question I had for you, Javier, and I don't know if it's a question that you can answer now, but it seems like the Mission Street Sobering Center has really morphed, because it went from a sobering center to addition of a mental health triage. And now it's got to be doing a whole lot of discharge planning. And I'm particularly curious kind of what happens with, I was looking at EPS is sending almost 80 or 60% of the folks that they send end up hitting there again. And they only have them for a very short window. So I think that their lift is very, very big. But so what is the discharge planning that they're effectively able to do in the very brief period that they're able to be connected to these folks?
Thank you, Aaron. That was a question that Supervisor Chavez had asked for us to address, and we probably will be bringing back more information. And that's what Horizon, the provider, is connecting with other services in the behavioral health array. And so we're looking at a deep dive in terms of some repeat individuals. So we had one individual that had visited the center 22 times. And we want to then start looking at the histories, like where were all the referrals made and where there were no connections. So that's something that I'll take back to the team and get more clarity, and then bring back to this team.
Wonderful, thank you.
Thanks, Paul.
Yeah, I just wanted to mention to Javier, so we just recently started having in-person briefings once again, which is terrific because it's so much easier to message directly to all the officers rather than try to do it through the supervisors. So if you would like to make another presentation on the center, particularly with the increased services that you're offering, I think that'd be a terrific thing, and just shoot me an email and I'll arrange it for you.
Absolutely, well, thank you. And then if there's a 6 a.m. briefing, I'll ask my colleague Bruce Copley to attend, or those midnight, we're ready.
So we got a bunch of briefings, morning, noon, and
Paul,
night.
Absolutely.
Yeah, and Paul, I'll tell you that I had a conversation with the district attorney, and one of the things that we were hoping to do was to have some food on the site and have give people the option to come over and take a look at it. And the reason is we did a walkthrough with Captain McFadden and his team. And one, they asked great questions. I mean, really helped us think about how to even improve services and communication. But the other is that I think when people see it, it makes a little more sense. Like, because Captain McFadden actually said, oh, you have showers, you have a rest, like you have ways for people to get kind of pulled together. So we'll reach out to let you know when we have snacks available, because we're going to do a round the clock snacks as a way to get people to come and look at the building.
All right. We'll come with snacks or no.
Okay, I really appreciate that. I'll tell you, it was one of the DA's office staff said food will bring them. I said, that's great. So good, thank you for that. Other comments or feedback that folks want to give? I just want to say, first of all, Javier, this is one of those areas where I just want to really thank the staff for how responsive you all have been to, our law enforcement partners. Second, I do really want to ask our staff to take a look at whether or not it makes sense for us to be receiving referrals from other agencies that we run, instead of actually connecting the people directly to a service. That doesn't entirely make sense to me. So I just want to better understand, what can someone get from us that they can't get from EPS, as an example, and then the only other thing that I wanted to add is that I think that, right now the Valley Homeless Healthcare Program, VHHP, I don't know why I can never remember the third letter in there, but anyway, speaking of more acronyms, Christine, but that program is looking at creating a wellness center and really a drop-in center for the homeless community. And it's on their to-do list, and they're right now working with the health and hospital system to look at a location. And one of the things that I just really want Javier to make sure that, and Miguel, maybe this can happen through you and Sherry, that I want to make sure that as the homeless healthcare program is thinking about a rejuvenation center, which is something that the Reentry Task Force had talked about a few years ago, whether or not there's an opportunity to layer up the sobering center and this kind of overall wellness environment for people. Because I think the point, Javier, you're raising about having fleets and facilities find the right sized location and the right opportunity. We thought it made sense here because it was an alternative to like the no entry center, but until we get this building rebuilt, which it absolutely needs to be as part of the the rebuild of the civic center, we might want to take this particular program and integrate it into another opportunity. And to Miguel and Javier and Sherry, there may be a building that one of our partners owns that they'd be willing to open up for us to have the sobering center and a rejuvenation center and a wellness area for people to be able to recoup. So I just want to make sure that those two planning processes don't happen distinct from each other unless we mean them to be distinct. We have one last item on our agenda, and it's 4 o'clock. And I know this is a very long meeting, but these are always such meaty discussions. What I wanted to do, if it's okay, can I keep people for about 10 minutes? The staff can present for about 5, and then we can, because I don't want to kick this next one. It may take too long for it won't come back to us till October. Is that all right with everyone? And I think this last item, Sherry, are you presenting on it?
Actually, Gabby Olivares will be presenting along
great.
with, we have Rachel Talamontes, one of our division directors, as well as Dr. Mira Sukumaran, one of our developmental behavioral pediatricians, as well, available here to answer any questions. So
excellent. Thank you for bringing your team. All right. Gabby, great.
Thank you. Rebecca, can you queue up our PowerPoint? All right, thank you so much. So we are here to provide a report out how autism can impact behaviors and contribute to an individual's involvement in the criminal justice. And we are here also to provide some recommendations for your consideration. Next slide, please. So given the time constraints, I won't read all the information, but what you have below is the definition from our Diagnostic and Statistical Manual, DSM-5, of what conditions need to be met for an individual to be considered ASD, and that is autism spectrum disorder. Just a quick highlight of some things is there's impact with social communication, social interaction, and there is deficits with social emotional reciprocity. Also, another thing to note is there's very repetitive behavior, and at least 4 of those have to be met to be qualified for this diagnosis. Next slide, please. So why this matters. An individual with ASD may face many challenges. One of those challenges, if they're in a custodial setting, they don't communicate. A lot of them are nonverbal. They have difficulty expressing what they need. They are very uncomfortable with eye contact, which may be representative as not being compliant by prison staff and also when they're arrested. Also, due to processing delays, when a lot of instruction is given by prison staff, that can be quite confusing. So a way to explain things is very simple and concise so an individual will understand. Also, individuals with ASD are more susceptible to being victimized, and it's best to keep them away from the general population when they're in custody. Also, they're very sensitive to loud noises and bright lights. Next slide, please. So, you know, what you have here before you are the 4 strategies that we're trying to implement as a behavioral health department to better address the needs of this population. Our first focus is on screening, assessment, and diagnosis, where we would add additional screening questions when an individual comes before us through the court process so that we can better identify somebody that we suspect could be ISD. This is a diagnosis that's given in childhood. So when individuals have come to us, they haven't been identified with this diagnosis. Also, we've done extensive lit reviews. There isn't standard assessment and diagnostic tools. All of the work that we've seen is done in the adult world, in the children's world. So with these additional screening questions, it would prompt us and our community-based organizations to further evaluate for better connection to treatment services. The next strategy is targeted services, interventions to improve outcomes for individuals with ASD, and to ensure that our county programs have the appropriate training and resources when these individuals come to them. Our next strategy is cross-systems clinical training and collaboration, which is to promote cross-training within our behavioral health treatment services department and extend that training to our substance abuse colleagues and our colleagues at the Reentry Center to ensure that we recognize and identify symptoms related to ASD. And then lastly, as I said, we've done extensive research, and there isn't dedicated tools for this population. But what we are doing is we have been meeting with HOPE and SARC services. We met on April 2nd, April 9th, and our next meeting is on April 26th. We will be meeting with the regional director where we are asking for dedicated training for justice-involved populations that have this diagnosis. Next slide, please. So through our collaborative efforts, we've been working closer with the San Andreas Regional Center. And what we have discovered is that they have service coordination. Individuals are assigned to a service coordinator who will provide feedback to the client, caregiver, and other family support systems, identifying the needs and services which will facilitate the achievement of those needs and develop a 1 to 3 year plan for clients. Services provided are case management and community services. Also, we have a court liaison that we're working very closely with, who is helping us better identify and contact SARC to determine eligibility. Also, for those individuals not connected to SARC, an intake can be conducted to determine eligibility. And we now have the number to the access line to make sure if we just need a case consult, we're unsure if we should send a referral to SARC. So again, we're working closer with SARC, and what they provide is psychological testing, reporting, and they will assign a social worker. Next slide, please. Our HOPE services. HOPE provides outpatient to individuals diagnosed with autism. And actually our department is fortunate enough to have a contract with HOPE services. Through our engagement and meetings lately, we have developed a referral process where now we're able to refer directly to HOPE services. They have evidence-based interventions and consumer focus on wellness and recovery for individuals. They provide a variety of interventions, support efforts to dually diagnosed individuals. Treatment methods include assessment, individual comprehensive treatment plans, and they address the physical and psychological conditions associated with developmentally delayed symptoms. They case manage, they brokerage, they provide rehabilitative services, collateral services, crisis intervention, and linkage to SARC and other Office of the Public Guardian if necessary. Services are provided in close collaboration with our Superior Court and other community resources. And we were fortunate to hire a staff that worked at HOPE. So that's really helped to broaden our understanding and connection to that program. So an individual with a developmental disability associated with ASD is arrested. There are 2 methods to refer that person and place them into one of our diversion programs. The first method is our behavioral health treatment court that is outstationed at Department 60 and 61 will request collateral information from adult custody health to help better identify if the individual was diagnosed with ASD based on the DSM criteria, or if they have, witnessed any behavior that would prompt us to further evaluate for ASD. Also, our behavioral health treatment staff conducts the assessment to determine a level of care placement. This assessment includes gathering past medical, educational, psychiatric records, and consulting with support people to build a rapport to assist the client in qualifying for this diagnosis. Our behavioral health team also will refer to other programs such as the California Department of Rehabilitation, the National Alliance of Mental Illness, and the SARC Day program. Next slide, please. So another method is, because we are in close contact with the individual's attorney, we will ask the attorney if they have any collateral information, knowing that this individual may have had a learning disability. Do they have any school records? And that will indicate to us that this is someone with an intellectual disability. Our staff will also determine if the client meets eligibility. Do they require ASD services or another specific level of care? If the individual is deemed eligible through the work with custody health, contacting SARC, we are able to place the person on the SARC calendar that occurs once a week. And otherwise, if the person is not SARC eligible, we'll go ahead and divert them into one of our regular behavioral health programs. Next slide, please. So our recommendations are to enhance the tracking of these individuals with ASD and to facilitate in differentiating this diagnosis with others such as TBI, fetal alcohol syndrome, and behavioral health plans to, again, add additional screenings in our integrated justice assessment, and to track this data in our electronic My Avatar health record so that we can have proper identification and administer these questions to prompt the collaboration with our community-based organizations to address the treatment needs. Also, we will continue to request collateral information from custody health services that will help identify an individual who has been diagnosed with ASD and refer to the appropriate agencies to continue with that comprehensive assessment, and if specialized services needed to be provided so the person can successfully integrate into communities. These steps will help assisting and referring individuals to agencies that will provide specialized services as our consumer tries to integrate successfully back into community. Next slide. So continuing with our recommendations, services and interventions aimed at improving outcomes for individuals diagnosed with ISD. So we are recommending a review of our current services to ensure that we have the proper services to meet the needs of this population. The goal would be to do a gap analysis of our current treatment system and make recommendations for improvement and expansion of services by which engagement in treatment is improved to support the linkage for individuals with ASD. Also, we will continue with our cross systems clinician training and collaboration. So beyond just the recommended training with SARC and HOPE, we're actually recommending that additional training, education, and awareness strategies to clinicians and other behavioral health staff to help recognize symptoms and signs of ASD, and that this training be focused around justice-involved populations. Next slide, please. And that concludes our presentation today. Thank you.
Thank you. Thanks, Gabby. And really, I wanted to say on the earlier report, if I didn't, just how far I think we've all come. So thank you for all the good work being done. I'm going to see if there are any members of the public who would like to speak. I see none, so I'm going to go back to my colleagues, and I'll start with Pablo.
Yeah, thank you very much, Gabby. Great report. I just want to just piggyback on that whole portion of the justice involved and the level of identification for this population. So we have a small program here that at Goodwill of Silicon Valley where we do our work that works with individuals that are on the spectrum. And because of the exposure that I've had as a director to integration between our programs, I was able to identify 3 individuals over the last 2 years that were autistic and nobody knew about it. So just and that's just based upon the basic understanding of some of the symptoms and some of the ways that they interact in social skills or responses to loud noises and other things. And we were able to reach and connect with our expandability program and just get guidance on how to approach the situation and to better serve them in the population in the model of our program. So I'm just very encouraged to see that, that we're taking a look at these type of things, and that just my basic understanding of a little bit of exposure was able to identify and help in those 3 situations. So that training initiative will go out to not just clinical, but community-based organizations as well, is going to be important and can make a great impact. So thank you.
You're welcome. And since you're one of our partners, I would like to invite you to the cross training once it's developed after we meet with the regional director from SARC. We'd like to invite you to participate in that.
I sent you an email while you were presenting already.
Oh,
so.
okay.
All right, you guys are already scheduled. Excellent. Molly, then Christine, then Laura.
Thank you. First of all, I think Sherry should be giving Gabby a raise. Those were very hefty presentations and really great. Thank you for that. I had a question for you, Gabby, about data, whether you have any idea of roughly the number of clients with ASD who may have been booked into the jail. And secondly, just a comment from having had cases where we had clients with traumatic brain injury or who were ASD, it's incredibly difficult sometimes to get at the diagnosis. SARC, if the diagnosis wasn't made before the person's 18, then the services aren't in place. And finally, we've had clients who may have spent a portion of their lives in another country, and gathering records to kind of support the diagnosis is incredibly difficult. So as you look at service gaps, I think that's certainly one of them to be mindful of the difficulty in getting those records, and also cultural competence in kind of getting family information about the story and the history. Thanks.
Thanks, Molly. Christine?
Thank you, Gabby. I really appreciated the report. I do appreciate you mentioning TBI and FASD, and I'm hoping that as we move forward with this model for justice-involved people with ASD, that all these neurodiverse sort of disabilities that are within our community get folded into this model, and that there's a better way to do evaluation and screening in, for example, a booking process or in the field. FASD is incredibly prevalent in the justice system. There was a recent study out of Canada that showed that individuals with FASD were 19 times as more likely to appear in the justice system than their typical peers. So, and it's far more prevalent just statistically in the community than ASD is. And there are ways to identify both TBI and FASD and a lot of other neurodiverse disabilities through the DSM, but not necessarily to get services through SARC. So we need to kind of look at all the ways that we can help individuals from being, to get them diverted away from justice situations. They are, as you said, incredibly vulnerable people, and much more likely to not be able to answer the questions of law enforcement or to admit to things they haven't done, et cetera, et cetera. So I hope that we continue to put a lens on all people with disabilities who have encounters with our justice department, so that they end up in the right kind of situations rather than in our jails. So thanks very much.
Thank you for your comments, Christine.
Laura?
Yeah, just real quickly, thank you, Gabby. Great presentation, and thanks for all the comments. Just to parlay a little bit off of this, I think when we talk about the neurodiverse population, it's really great that we're partnering with San Andreas and with other providers, and that we can't forget that that doesn't necessarily make people competent to stand trial. It doesn't necessarily make people competent to be in the system. And while we should partner with our partners, we also should be really careful that we're not the default housing and care situation for people that have limited options.
Yeah, I think one other point, Laura, that you raised that I just want to pick up on is that, there's been a lot of advocacy in state legislation that focuses on children, and not very much as it relates to adults. And because of that, there aren't a lot of resources or services from when you're 18 on. And so I think you raise a good point. And I also would just say that, one, I think this is a really good dive into an area that we need to better understand as a community, and also with this particular subset of our responsibility as it relates to public safety and justice. What I would like to ask the staff, because you had some really great to-dos in terms of recommended next steps. What I'd be really interested in doing is having you all come back, maybe not to our next meeting, but in 6 months, with just where we are in process. And in particular, Gabby, one thing that I just want to reinforce a point that Christine raised, which is that in some ways we're going to have to think about screening in a very different way than we had before. And I think a lot of our screening, whether it's with youngsters or young adults or even adults, the psychosocial screenings that we're doing now, we've got to figure out how to do them a little more quickly, and especially when someone has an interaction with our systems, so that we know what we're dealing with. And in some instances, being able to make that record available for other service providers that they're going to need services from. And then the other is, as our public safety and justice system gets more connected to Epic and to these other kind of shared record keeping, it really is an opportunity for us to essentially give somebody a passport, right, to get the services they need, even if they're adults. But I would just say that one other thing that I hope comes out of this is that as we look at our legislative portfolio in the future, that we're a lot more active relative to high need populations. I think in particular, autism is growing so much that if we don't really get our arms around making sure that the state understands their role and the federal government understands their role as it relates to adults, is that'll be the next group of people filling up our jails. So we ought to play a leadership role in making those cases. We'll think a little bit more about how to do that. I don't see any other comments from my colleagues. I know this was a very robust meeting. I deeply appreciate you all staying with us. Our next meeting, I just wanted to highlight, is our next meeting is going to be in June, and it'll go from 2 to 5, and that's so we can accommodate a study session of public safety lessons learned during COVID-19, things we had to keep doing that we learned worked. So I want to make sure we have time for all of that. And I really appreciate all of you very much. Please have a safe day, and thanks for letting me keep you so much longer than I was supposed to. Thanks, everyone. Be well.
Thanks, everybody.
Thanks, everyone.
Bye.
Thank you.
Meeting has officially adjourned. Thank you.